Hello and welcome. My name is Dr. Muhammad Saif Ali Memon, and today's topic is about ankylosing spondylitis. So, first of all, we will discuss the case about ankylosing spondylitis and boy present with a recent history of tender temporomandibular joint and regular morning stiffness in both hips. He has a limited range of movement in his hips, especially abduction and adduction, and is no longer able to run and play games with his brother. So, in your mind, there are many differential diagnoses will occur. So, first of all, we will talk about the history of the patient. What is the history the patient has given to us when he come into the OPD with this complaint? So, he's saying that he is suffering with painful hip from age 14, and within the month he was unable to walk unassisted. Means he can walk with the help of another person or with the help of any instrument. The pain presented with the typical feature of inflammatory response, that is worse in the morning and improving with activity during the day. Minimal relief was obtained from paracetamol because it is an antiprostaglandin drug, so that's why he was having a relief with this medication. Associated features including occasionally fevers, malaise, weight loss, no skin rashes, no urogenital symptoms, and no visual impairment. Focus past medical history: intermittent pain in the left and right groin for the past 2 years. Age 11 years. He had uncomplicated nephritis. Okay, this is an important point that he is having a uncomplicated nephritis, and at the age of 10 he is having a infectious mononucleosis. So, what are the differential diagnoses in your mind comes? So, he was giving a history of joint pain. So, in the joint pain, you are having a many differential diagnoses, but the age of a patient is very small. So, these rheumatological diseases are uncommon in children, but there are some diseases of the rheumatology which come in the age below the 20 or 30. So first of all, there are the differential diagnoses which come into your minds according to this history and the case. So first of all, the first differential diagnosis is reactive arthritis. What is the reactive arthritis? We also said the reactive arthritis is known as a Ritter syndrome. In this syndrome, there is a triad of three diseases. There is a triad of disease like conjunctivitis, urethritis, and arthritis. But there is no any conjunctivitis, no any urethritis, so it is excluding from the diagnosis. And there was one more diagnosis, differential diagnosis, is oligoarticular juvenile rheumatoid arthritis, because the juvenile rheumatoid arthritis, as the name indicate, that it come into the age of juvenile age like 14, 15 or 20 age. So it can be a diagnosis of this disease, but we are more concerned about the ankylosing spondylitis because it is a pure case of ankylosing spondylitis, and it is also can be due to psoriasis, because the psoriasis is also an autoimmune disease, and the psoriasis, few cases, 3 to 5% of the people with psoriasis can undergo psoriatic arthritis. So we have to keep in mind that the psoriasis can also do the psoriatic arthritis. So what is an etiology of an ankylosing spondylitis? It is a very, very complicated disease for a patient who have been occurred in this disease. So the etiology is a genetic background. There is no any major etiological factor has been included in this disease. So there is a genetic background. Most common etiology of this disease, there is a microbial infections, there is an endocrine abnormality, but it is of unknown pathogenesis, that here it is having no any such pathophysiology that can say that yes, it is a pathophysiology of the disease. So we will talk about the pathophysiology, which is normally an autoimmune disease. So in autoimmune disease, there is having an activation of the T lymphocytes or T lymphocyte cytotoxic T cells and helper T cells and many other cells which are involving in the inflammation of joints mainly and other connective tissue. So ankylosing spondylitis is a potentially disabling form of seronegative spondylitis. Very important thing. Very important. Seronegative means that when you take the sample of the serum from a patient, so there is no any antibody in the patient serum, like rheumatoid factor in the rheumatoid arthritis, it is positive for the rheumatoid arthritis rheumatic factor, but there is no any such rheumatic factor present in the seronegative spondyloarthritis. And these all four conditions which we are talking, like Ritter syndrome, like psoriatic arthritis, like ankylosing spondylitis, these are the seronegative types of spondyloarthropathies. So the main symptom of the ankylosing spondylitis is inflammatory spinal pain. With time, some patients develop ankylosis and spinal immobility. So we will talk later that how they develop ankylosis and immobility. The pathology mainly affect the entheses. What are the entheses? The enthesis is the place in the joint where the ligaments, tendons, and capsule are attached to the bone. Three processes are observed at the enthesis: inflammation, bone erosion, syndesmophytes, spur formation. Spur formation means that there is small bones which occur from the bone, small bones which produce from the bone is known as spur formation. Spur formation. Tumor necrosis factor is an important mediator of the inflammatory process, but this pro-inflammatory cytokine is not closely involved in bone erosion and syndesmophyte formation. The major causative factor of ankylosing spondylitis, as told before, that it is a purely genetic factors like HLA-B27. The patient which is heavy, which are having a genetic code encoding of HLA-B27 are more prone to this for this disease. So we have to see the patient with HLA-B27 for the diagnosis of the disease, but it is not compulsory that every patient with ankylosing spondylitis is having the HLA-B27 antigens. Okay, there is a normal lumbar spine curvature within the vertebra, and this lumbar spine curvature has been destroyed, has been removed from the vertebra because of the fusion of the vertebra occur. So like the third picture, which is seeing that there is a fusion of the bones, and the bone is having a characteristic picture of a bamboo spine. What is a bamboo spine? That there is a tree, a plant which is having the straight stem, which is growing very much. So in the healthy individual, this is a healthy spine, and in the healthy spine there is a body of vertebra and the disc, and between the two body of the vertebra there is an intervertebral disc which play an important role in providing the cushion between the two vertebrae and in relieving and preventing the friction between the two vertebrae. So it is very helpful in the movement of the spine, so we can flex or extend our spine. And there is another joint which is a spinous process in the spine. So there is a facet joint which is helping us in the mobility of the spine. So these two places which are involved in the ankylosing spondylitis, one is the intervertebral disc, and other is a facet joint. When there is an inflammation occur between these two things, between these two places, so the spine of a person is having the inflammation and the disc has been destroyed, and between the two bone there is no any space between them, and these two bones or these two vertebrae are joined together and they are having the fusion of the bones, and it is known as the ankylosis. Ankylosing is name derived from the ankylosis which occur in the spine. So the spine has having the ankylosis, and these spine have been fused and they are having in shape of a bamboo spine, the bamboo tree. Okay, now there is a curve, there is a normal curve in the healthy spine at the lumbar area. So this curve is very important for a person to having a good movement, but whenever there is an inflammation of the spine occurs, so this curve has been destroyed, or so this curve has been removed, so the person spine is become straight and there is no any movement occur in the spine, no neither flexion nor extension. So it is a characteristic feature of an ankylosing spondylitis. So what are the clinical features of a patient with ankylosing spondylitis? So first of all, it is a male predominant, because many diseases which occur in male, many diseases which occur in female. So it is a disease which mainly occur in the male, and the age of a person is between the 20 to 30. It can be 40, it can be below the 20, but the mean age of a patient is between the 20 to 30. And the characteristic feature of a patient, what he is saying, that he is saying that he is having a back pain involving vertebra, and the one most important thing which is a characteristic feature of an ankylosing spondylitis, he will say that he is having a pain at the hip because it involves the sacroiliac joint, and it is known as a sacroiliitis. What are the characteristic feature of the sacroiliitis? There is an insidious onset. The pain always occur at night, because at night the patient is having a rest, and this pain is increase with rest and improve with exercise and hot water. There is a morning stiffness occur. Every rheumatological disease is having the morning stiffness, and there is a duration of the morning stiffness. Some having the less than 30, some having the more than 30. So it is having the less than 30. Flattening of the normal lumbar curvature, and along with the sacroiliitis, along with the spinal vertebral inflammation, there is a peripheral arthritis which mainly involve the lower limb more than the upper limb. There is an enthesitis. What is enthesitis? I have told before that the place where the tendon, ligament, and bone are attached. So it is a site of inflammation. So what are the extra-articular? The intra-articular features we have discussed that there is a sacroiliitis and spinal involvement, but the most important thing in this disease is that there is an involvement of the extra-articular component also. So first of all, most commonly the patient come in an IOPD will complain of recurrent anterior uveitis. So ophthalmologists have to be exclude the disease why he is having an recurrent anterior uveitis. So when you do the investigation, so it is confirmed that it is having the patient is having a ankylosing spondylitis. He is also having a conjunctivitis. So what is anterioritis? I am telling you that it is an anterioritis. In the anterioritis, the uveal tract which composed of choroid, iris, and ciliary body. So these three parts are the component of the uveal tract, but the anterior part is the iris and the ciliary body. So these are very much involved in the anterioritis, and there is an redness of an eye. There is an pupil is become irregular because of posterior synecdoche. So these are all the conditions which occur in the anterioritis. There is a conjunctivitis. It is also a condition of an eye. There is a cardiac aortic regurgitation because there is an aortitis, because it is an inflammatory condition and whole of the body is involved in this condition. Multi-system inflammatory condition it is. So there is amyloidosis, deposition of abnormal proteins, pulmonary fibrosis. So the patient has come to the pulmonology OPD with this condition. He is having a whole pulmonary fibrosis occur in the lungs, and it can be a cause of death. Neurological, like spinal fracture, cauda equina syndrome. In the cauda equina syndrome, what happened that there is an inflammation of the spine occur. So that's why there is an compression of the cauda equina, so that there is an paralysis of a body also occur. There is a prostatitis, but prostatitis is an asymptomatic condition. Now what happened? So when the patient come to an OPD, so you have to do the diagnosis of a patient. So the most important thing for the diagnosis is baseline investigations like CBC and everything else. But in the CBC, you have to see the ESR, erythrocyte sedimentation rate, which is increase in inflammation, and it is a type of inflammatory disease. So ESR will be elevated, C-reactive protein is also elevated, and the HLA-B27 will also positive because the genetic predisposition is of person who is having HLA-B27 gene is more prone to having an ankylosing spondylitis. Not always. It is not a confirmatory test that he is having an ankylosing spondylitis, but in most of the cases of the ankylosing spondylitis, it is positive. So first of all, we will do these tests, diagnosis, serology, and after that we have to do the imaging which give the best result regarding the ankylosing spondylitis. So first of all, the best initial test is an X-ray sacroiliac joint. What happened in the sacroiliac joint? There is an erosion and sclerosis of the sacroiliac joint, and we will do the X-ray spine. There is a bamboo-shaped spine due to fusion of the vertebrae, as I've said previously. The most accurate test is an MRI spine. So we will do the MRI spine. The treatment, as you know, that the rheumatologist have only an option of decreasing the severity of the disease. It cannot be reversed. The disease cannot be reversed itself, but we will delay the progression of the disease. We will decrease the inflammation process which occur in the spine or sacroiliac joint. So first of all, we have to do the counseling from the patient that you have to be careful about your posture, about your exercises, because that exercises play an important role in the prevention of the ankylosing spondylitis. We will give the first line management for to this patient is an NSAIDs, because NSAIDs are the anti-inflammatory drugs which reduce the pain and also the inflammatory reaction within the body. But as you know, there are many side effects for long-term taking of a NSAIDs. There is a gastrointestinal symptoms like gastritis, peptic ulcer. There is a renal function disease occurred due to long-term taking of an NSAID. There is a cardiovascular events occurred due to taking on of NSAIDs. So we will switch the patient to the anti-TNF therapy if the NSAIDs are not working or the NSAIDs are doing a side effect. So anti-TNF therapy like Intercept, Infliximab, these are also the tumor necrotic factors, anti-tumor necrotic factor therapies, which play an important role in reducing the inflammation of the joints. And after that we have a DMARDs, which is methotrexate, but it is not used for the prevention or cure of the disease of the joints, but it is important for the cure of a or disease like uveitis, like aortitis, like prostatitis. So it is helpful.